Okay, so you go up in the vagina, you go up kind of past where the uterus sits down in the pelvis, and you can feel these little protrusions with your finger, okay? And if you press on them, it will hurt because they have a lot of nerves that run behind them. And then you measure with your finger, again, where that biparietal diameter is in relationship to that protrusion that you've identified. So obviously it takes a little time and practice. You've got to feel a few vaginas to get that. But anyway, that's a very important assessment for the nurse to do in terms of labor progress. Now, powers of labor, when we talk about that, we're basically talking about contractions, all right? And we have ways to influence contractions. We have things that we can do as healthcare providers to help contractions along, make them more strong. We have things that we can do to make contractions go away as well, particularly if they've come at a time when we don't want them, like prematurely. When we talk about contractions, we're going to talk about it in terms of, we will talk in great detail, let me say that, about contractions when we talk about fetal monitoring. So we'll talk about how we define them and how we assess them. But contractions can be influenced by a lot of things. They can be influenced by infection. They can be influenced by uterine bleeding. They can be influenced by use of drugs. They can be influenced by oxytocin, which is that hormone that causes the uterus to contract. And we can give oxytocin through an IV, okay? You might hear it called Pitocin when you're at the hospital. But we can give oxytocin through the IV and cause contractions to occur or to be stronger. So we can do those sorts of things to help labor along if it's necessary. The secondary powers are what mom puts behind the contractions of the uterus. And that's sort of the expulsion of the fetus. That's a voluntary aspect. In other words, she is working with the uterus to push the fetus out. And how effectively she's doing that can depend on a lot of things. It can depend on whether or not she's in pain, or whether or not she's really, really tired, or whether or not she's really, really, really well medicated and can't feel her body from her umbilicus down. So, you know, you tell her to push, and she's like, I can't feel a thing. What do you want me to push? So, so pushing is somewhat the body and somewhat the mommy. And so this picture here is actually a really nice example. And this is actually a really nice way to push. You just don't see it very much in hospitals because, you know, then there would be two people in the labor bed, and that wouldn't be good. And yeah, so anyway. But it's really nice because moms get very tired of pulling their legs back. Did anybody see mommy pulling legs back, or did you hold legs when you were doing your delivery? Okay, if their legs are medicated, then they weigh, and they don't have any sensation in them. They're heavy, they're tired, and so this way, you know, the coach, the support person, dad, can help with supporting mom and with supporting the legs and help with pushing. We'll talk in a minute about pushing when we get into the stages of labor. So I want to go through these, and then we'll take a break, okay? When we talk about the labor process, there's 4 stages. We're going to talk about 3 of them today. The first stage is the actual labor. The second stage is pushing to delivering the baby. And the third stage is the placenta. And then Professor Walker will talk about the 4th stage, which is recovery, next week. Okay? The first stage is the dilation stage. And that is probably the longest stage. And it's probably the hardest stage for most women. This is when the cervix dilates from 0 to 10 centimeters. And this is very chewed up, but it's a good example of this is a cervical exam trainer. And it's seen better days. But basically, if you're a nurse in labor and delivery and you're learning how to do vaginal exams, you're either going to be doing them before and telling what your guess is, and then the other nurse will follow behind you, or you're going to be doing them afterwards, okay? And then you're going to check to see if you're right. So this is about 1 centimeter dilated, which would be like that. Okay, so 2, 3. You know, so when I learned, 2 was kind of crossed over. 3 was my 2 fingers together, just a scotch apart. 4 was with 1 finger between. 5, and so I kind of, you know, taught my brain how to recognize how far apart my fingers were. So we've got to get from here to here, okay? That's the effacement and the dilation part. And that does take the longest amount of time. And primiparas usually dilate about 1 centimeter an hour, multips about 1.5 centimeters. So the good news about having more than one child is that it does get faster as you go along, in most cases, hopefully. But we can guesstimate, if we have a multipara patient, that you're going to have a faster labor than your peer who's got a prima gravida. So I would just say, in order not to miss a delivery, if you have a multigravida who's 7 centimeters, you need to stay put until the baby's out. Don't go eat lunch. Right? I'm just saying. I've had students miss deliveries because they were eating lunch. Yes?
I had a 7 with a multi, and then within 10 minutes, the baby was out.
There you go. Sometimes
it
does not
happens
take long.
fast.
Yeah. Now, this first stage, this dilation stage, has 3 phases. There's early labor, there's active labor, and there's transition, all right? And so they're defined here, all right? Early labor is when the cervix dilates from 0 to 3 centimeters, and effacement is partial. So the cervix is partially thinned out. And you can see that the contractions are not very frequent. They're 5 to 10 minutes apart. They're mild. They don't last very long, 30 to 45 seconds. Usually moms are very talkative during this period of time. For the most part, I'm talking about sort of the average, okay? They're usually talkative, they're usually social. They're usually pretty happy that they're finally in labor and they're going to, have this baby and not be pregnant anymore. Oftentimes they're not particularly uncomfortable, and that can be deceiving because if they've never had a baby before, they might think this is as hard as it gets, and that is not true. Oftentimes in early labor, they may say, oh, no, I don't need anything for medication. Sometimes patients will come in early labor and they're like, this hurts already, I would like drugs. So every patient is different and their perception of pain is different. In early labor, if they do want medication, sometimes a healthcare provider will give a narcotic or a sedative to let them sleep or rest. Okay, sometimes. Okay, and we'll talk about some of those drugs in a minute. Oftentimes, however, what they'll do is they'll start an epidural and maybe give a very, very small dose. Okay. The problem with any kind of medication in early labor is that it confines the patient to a bed or a chair, okay, and probably a bed and a monitor. And really early labor is optimal for the patient to be up and walking around because gravity is what brings the fetus down into the pelvis. Gravity is what helps facilitate descent. Walking and moving are what facilitate and help facilitate contractions. And so a patient that's in early labor really needs to be up. They need to be walking, they need to be sitting on the bouncy labor ball, they need to be taking a shower, they don't need their IV yet, so you need to be giving them ice chips and popsicles, They need to be up and moving, and then you need to be monitoring the fetus. They may be attached to the monitor, but the monitor's got a long leash, so they can at least walk around the room, they can change position. Ideally, if they haven't ruptured their membranes, where do you think the best place for them to be is at this point? At home, exactly. As long as they have a term pregnancy with no complications and they're not ruptured, there's no reason why they can't be at home. Please remember that we have been delivering babies since people existed. And it's only been in the last 150, oh gosh, what is this, 2013, so, 150, 160 or so years that we even thought about delivering babies anyplace else but in the bed, in the back bedroom, So we've been doing this for a really, really, really long time, and for most of that time, nobody's had to get into a hospital as soon as they felt a labor pain. So we have to keep some perspective on this. This is a normal process, all right? And we need to allow that to be the case if everything is okay. So pain management, again, very individual at this point for the mom. Some people want nothing, some people want everything. But in early labor, they're probably not that uncomfortable. Now, once they get into active labor, which is the second phase, they're going from 4 to 7 centimeters, things kind of pick up. The pace kind of gets a little bit more accelerated. Things get a little bit more intense. The contractions are closer together. They're stronger. They last longer. And so when we think about contractions, what we are looking for in any labor is longer, stronger, closer together. As labor progresses, we want to see contractions get longer, get stronger, and get closer together. And of course, as that occurs, and as dilation occurs, and as the fetus is moving down, and there's more pressure, and there's more discomfort, we have an increase in our pain, right? And usually active labor is when moms, if they want pain medication, will decide that, yeah, that probably is a good idea. This is not so fun anymore. And if they're a first-time mom, I didn't quite realize that when they said it really hurt, that they really meant that it really hurt. But it does really hurt. So perhaps some medication would be a good idea. So the pace is increased. The mom is less sociable. She's more focused on the contractions. She may ask for pain medication at this point in time. And she's much more anxious. And, I think that the goal for any kind of labor and delivery is that we want the mom to feel like she's participated in the birth and that she has been able to, I think enjoy is probably too strong a word because I'm not really sure that you can enjoy this, but that she's participated in it and it's not been out of control, not felt like the birth was this thing that just, horrible thing that happened to her. We want it to be positive because certainly there's going to be, this really good thing at the end. So, pain management would be an epidural at this point, and that's completely appropriate, and this is really the optimal time for her to get it. Okay, because somebody said they had a patient who wanted an epidural or who had a natural birth and didn't want to have a natural birth. Was that you?
Yeah.
Okay. Do you know how far along she was when she came in?
I think she was 2.5.
She was
2.5. She was dilated 2.5.
okay.
Yeah.
Okay, but they just didn't get an epidural in her or something? No. Okay, that's unfortunate. All right. So we'll talk about pain management in a minute, but this is the time to get it because once we get into transition, it might be too late, okay? Transition is really, 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 really where, where things really get serious, let's put it that way. where if you haven't noticed you were in labor, you'll notice it now, yes.
My multi that, from 7 to 10 went in a few minutes, they were trying to give her an epidural. But she was really anxious, and the anesthesiologist kept saying to her, you need to cooperate with what I'm trying to do here, or it's going to be ineffective. And she wouldn't pay attention. She wouldn't round out her back.
She was in transition.
He got impatient with her. Apparently the epidural didn't make a dent.
Oh, I'm sure not if she was in transition, yeah.
So I guess the nurse's role would be to try to help her get into that position, but my nurse wasn't really paying attention, and the anesthesiologist was saying to the nurse, pay attention and help me here. So it was an odd kind of situation,
Yeah, the nurse's role in epidural anesthesia administration is to facilitate that process. And that is to work with the anesthesiologist to get the patient in a safe and appropriate position and to try to manage their anxiety, their contractions, the fetal heart rate, the meds the anesthesia needs, the IV, etc., so that this medication can get in. But if you have a patient who's in transition and she's feeling the baby right here and she's basically sitting on its head, it's going to be hard for her to focus. And it might have been at that point appropriate to get the OB in and say, let's take a look at her. The baby might be ready to deliver, in which case the epidural is irrelevant. So that's an unfortunate situation.
That's what happened. It became irrelevant. And the husband was there, and he kept saying the husband needs to sit down, and he wasn't sitting, and he was trying to get the nurse to do that, and it was chaos.
Yeah, that's too bad. Yeah. Because sometimes labor is chaos, but that's not optimal for the patient. Yeah.
Doesn't it sound like it was just too late by the point they thought about it?
It probably was too late, but they should have evaluated it was too late. They should have checked her and said, oh, guess what, baby's right here. Let's get ready for delivery.
Does she have to be sitting up when the epidural goes in? Could she be laying down on her left side?
She could be laying down on her left side. I mean, people anesthesiologists prefer different positions, so certainly lying down on her left side, but if she was in transition, she probably could have been delivering the baby as he's putting the needle in. So anyway, we're kind of getting off track here. So transition is when we get completely dilated. This is when you see bloody show, okay? And bloody show is bloody. That's why it's called bloody show. Red, dark blood, bright red blood, it's capillaries and little vessels that are fracturing and breaking in the cervix. mixed with potentially amniotic fluid, remainder of the mucus plug, etc. And usually you see bloody show expelled as the mom goes into transition. So if you're in a patient's room and the patient is saying, there's a lot of stuff down here on my pad, I felt like stuff coming out of my vagina, you know, and you check and there's a lot of blood, then you need to either call your faculty or call your nurse or call both, because the patient needs to be evaluated. Because chances are very good that she is moving towards the complete, that she's in transition and she may be ready to push. So we can see that the contractions are longer, stronger, and closer together. They're very frequent, they're very strong, and they last like a minute to a minute and a half. So the mom is getting very little rest between these contractions. And that's where sometimes fatigue will set in, particularly if the labor has been long and perhaps if she's unmedicated. Now she's going to feel pressure on her back and her rectum as the presenting part moves down through the pelvis. And is coming out the other side and is coming down onto the rectum. Because remember, the vagina's here and the rectum's here. So anything that sits in the vagina, okay, you're going to feel pressure in the rectum. So we call that rectal pressure, and that would be also called urge to push. She wants to bear down and get the baby out, okay? And at this point, as was pointed out, if a patient is in transition, she may not be able to cooperate with an epidural, and there is no point to an epidural because the baby, if it's moving along the way we anticipate, it's going to be here before the epidural gets in. So what would be the point of the epidural? So we need to kind of pay attention to that process. And also, that does speak to some patient teaching on your part if you are taking care of a patient and they're in active labor and they are trying to decide whether or not they want an epidural or not. I'm not saying that you need to have a bias one way or the other, you know. What I'm saying is the patient needs to be aware that if she doesn't choose to have anesthesia during her window, okay, up through active labor, she may not be able to have it later. And so she needs to know that. All right. Now the second stage, we're going to deliver the placenta, we're going to take a break, okay? The second stage is called the expulsion stage, and that's basically the pushing stage and the birth of the baby, all right? So the end of the second stage is the time of birth. And pushing can be very, very quick. You know, 1, 2, 3, the baby's out. It can last an hour, 2 hours, 3 hours, 4 hours, etc. The fetus is going to continue to descend by the pushing of the uterus, the contractions of the uterus, and also the bearing down of the mom, okay? And the mom needs to be using, at this point, if she is pushing, she needs to be using, well, here, we'll show it here first, the muscles that you use to push, okay? And you don't use your cheeks to push, and you don't use your shoulders, and you don't use your belly. You use these muscles right here. Okay, these are the sympho-pubococcygeal muscles. All right. Sympho-pubococcygeal muscles. Okay, they go from the pubic symphysis to the coccyx, like a hammock. They kind of lie like that. You can see them. They attach here, and they attach back here. All right. They're the muscles that surround the urinary meatus, okay, surround the vagina, surround the rectum, all right? And so they are used to expel urine, babies, and feces, okay? And so those are the muscles that a mom needs to use to push. And in sort of relatable terms, if a mom knows how to do a Kegel exercise, which is the exercise where you tighten and stop and start your flow of urine, that's the muscle that you're using. So if she knows how to do that, that is the muscle she needs to push out, okay, to push the baby out. Now, suppose she has a really, really, really good epidural. What do you think would happen? She can't feel her sympho-pubococcygeal muscles because they are numb, okay? So sometimes moms will get to 10 centimeters dilated, and the nurse will check the patient, and she's dilated, but she is still so nicely medicated that she's not even aware that she's ready to push. So then what will happen is the nurse the nurse's wisest move or priority would be to have anesthesia come in to evaluate the patient, to turn down the epidural, and to let the medication wear off until the mom can actually feel the contraction so she can push. Now what that does is two things. It gives the mom a little time to rest, okay? It gives her body some time to adapt to not medication and get ready to push. The other thing it does is it buys some time. So during that time the mom is resting and the medication's wearing off, the uterus is still doing its job, so it's pushing the baby down. So it kind of gets her a little head start. Okay, so by the time she's ready to push and she can feel it, the head might be further down in the vagina. That's called laboring down. So you often see that, laboring down. Mom's just resting, medication's turned off, waiting for her to feel the urge to push. Sometimes, as I said, pushing can take a really, really, really long time, and in which case you might have an assisted vaginal delivery, okay? So this is a piece of equipment. It's part of a vacuum, all right? And this would attach to the fetal head at the occiput by suction. A little vacuum handed off, and the physician pumps it up, or the healthcare provider pumps it up, attaches to the head, and then it just helps guide the head out of the introitus of the vagina at the bottom of the perineum, just to guide it, just to give a little extra help, okay? So that's usually your first resort when you have a mom who's really, really tired, having a hard time pushing that baby out, or if the baby is starting to have some stress and needs to get out, quicker than she can push it out. The second, the second option would be forceps, okay? And these are called closed Simpson forceps. There's all different kinds. There are different kinds of shapes and stuff like that. Basically, these go around the presenting part. Okay, so the physician would put one in. They sit like this around the face, okay, and then would slide the other in, and then attach them. And this is when I need like 3 hands. Hang on.
Mini golf.
Like that. There we go. Okay, and so again, the forceps would be just used to guide the head out, or the presenting part out. Okay, and then they would be taken off, and mom would push the rest. Babies that have the vacuum oftentimes have bruising where the vacuum site was. Babies who have forceps oftentimes have bruising across their cheeks and up across their ears. So forceps are kind of a last resort before a C-section. So, if that is the case, then you would be asked to, get that equipment and assist with that delivery. Now, prior to the actual delivery of the head, the healthcare provider may cut an episiotomy, which is an opening from the bottom of the vagina towards the rectum, anus, or the tissue may tear, one way or the other. That just widens the opening so that the fetal head can come out. And then the fetal head is going to come out, and typically it comes out like this, okay? If it's an ROA or an LOA position, occiput first, head comes out like that, and as it comes out of the maternal body, it's going to start to rotate somewhat like that. The healthcare provider is going to check for a cord around the neck, make sure there's no cord. Where's my cord? There's my cord. Okay, my cord. So if there's a cord around the neck, we'll talk about this when we talk about monitoring. We may have seen some interesting fetal heart rate tracings. They're going to slip the cord, or they may just clamp it and cut it, depending on how tight it is and how many times it's wrapped around. Okay, then they're going to suction out the nose. They're going to suction out the mouth. Then they're going to deliver the anterior shoulder. Then they're going to deliver the posterior shoulder. So as you as a nurse, if we're at this point and the posterior shoulder's coming out and you're doing the delivery, what should you be doing?
Putting warm blankets on the mother's abdominal.
Okay, warm blankets. Huh? Catching the baby. You wish you're catching the baby. Well, you should be watching the fetal heart rate, but by this point in time, you probably aren't getting one. You definitely should be ready for the delivery, which means that you should have warm blankets and the warmer turned on and the resuscitation equipment set up, okay? Because you will be doing the resuscitation if you were the labor and delivery nurse, unless you've got peds there because there's been a problem. So, okay, if it's me, I'm going to hope that I'm delivering this baby to this tummy, and we're just going to dry right here, okay? So, once the shoulders come out, then everything else just kind of slides on out, okay? And in theory, we should be hearing wham, 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 seeing nice pink baby as it comes out. So we're going to take a break now because Professor Walker appears to have the quizzes. And I'll come back in 10 minutes, okay? And I will pass these out as I'm going. And it looks like she might have an announcement. Oh, Lord have mercy.
We have
And
two Scantrons
we'll talk about babies.
in this building, and neither one of them are working.
Awesome.
So, we have a call into the Scantron people, and they said maybe by the afternoon they would be here. So, all I could do is give you your grade now. You don't need to be waving it around. But when the Scantron is fixed and we run them through, we hand graded them. We will analyze the questions for any statistics that would allow us to toss out any questions. So this is the standing now. When they're run through the computer, there may be an adjustment, so just watch on Blackboard.
Okay.
These will be put in this afternoon, but they may not be the permanent ones.
I got 5.
All right, so we're going to take a 10-minute break, but I'll start calling out names so you can get your little post-it notes. I'm sorry.
I saw Darian section.
Uh-huh.
Today, so because the national, you don't have to suction.
I know this one.
No, they still have to suction.
They do.
Yeah. I see. Because they haven't gone through